Hi guys, it's Shad again, and I'm here to teach the principles of physiology. Today we will be discussing the composition of the blood and what's in the blood and how we use it in our bodies, and what happens to our blood when we recycle the components of it. We'll also be talking about a concept called hemostasis, which is basically how blood clotting works in our body. And so, let's first talk about the composition of the blood. So, if we were to take out our blood and just put it in a container here, we would find that our blood consists of multiple layers. There we go. Alright. So, let's say we were to measure this flask where we took out our blood and put the continents in it. Say we had 100 millimeters of blood. About 40 of those millimeters we would find that about 40 millimeters of that blood is made out of hematocrit. So here, this is our hematocrit. Hematocrit is basically just our red blood cell count. Hematocrit is our red blood cells. We also find a layer of white blood cells in there, and then the rest of it would be plasma. So this orange here that I'm drawing out is a plasma. So here we have white blood cells. And then our plasma. When you think about the composition of plasma, if you've ever donated plasma before, the reason that they want your plasma is because your plasma is packed full of proteins. And those proteins can be beneficial when trying to find treatments and cures for different diseases. But let's talk about the plasma really quick. So, like I said, our plasma is composed of mainly water and various proteins. If you were to take your plasma out individually of your blood and run a gel electrophoresis test on it, which basically means you have your positive and negative sides of the test running here. You would find that your plasma has a couple of bands that are of interest. So, here in this first band, this would be mainly composed of your proteins, and the biggest protein in the plasma is a protein called albumin. So that's going to be our first hump there. Our next one is our alpha and beta components of plasma. So the alpha and beta components of plasma would be the next humps, and the last one would be the gamma globulin. This is alpha globulin, beta globulin, and gamma globulin. So in the gamma globulin, we have antibodies in here. And so, yeah, I'll just write here, this is your antibodies. And like I said, you have your alpha and beta as well. And they just help with various functions in the body. And they're also important for immune defense. But let's now talk about some other components of the blood. So that's your plasma. Where your main things that we're really going to highlight here is the antibodies, which are found in the gamma subunit, the gamma globulin, or the gamma plasma component, right? Now let's talk about the red blood cells. So we'll spend a little bit of time on those right now. The way that your red blood cells are made is your body, your kidneys. So I'm going to draw a little picture of a kidney here. And in this picture, I'm going to draw the bloodstream running through it. And draw some cells here. Cells in the kidney. So blood is going to run through the kidney. If the blood has low oxygen levels, then the kidneys are going to release something called EPO. EPO is released into the bloodstream at the kidneys, and this is in hypoxic conditions, meaning very low oxygen in the blood. And this triggers the release of EPO, which is erythropoietins, and these will then go from the kidney into the bloodstream. Eventually they'll travel through the bloodstream, and they will make their way to... So we get into the bloodstream, they'll travel through the bloodstream, and then EPO will basically target red bone marrow to start making more erythrocytes. So EPO travels through here, and then will go up into bone marrow, and this will trigger the production of erythrocytes. And these erythrocytes can now become new red blood cells. And as we get more new red blood cells, we're able to efficiently transport oxygen throughout the body. And so this is kind of the formation of red blood cells here. That's what's happening. Now let's talk about in your hematocrit, what is actually there. So let's look at the components of it. So, excuse me, the biggest component of our red blood cells is hemoglobin. Hemoglobin is found within our red blood cells. So I'm going to draw up a little picture here. Let's pretend that's a red blood cell. And within this red blood cell, we're going to find hemoglobin. And I'm not drawing this the best, but that's okay. Just to get a visual idea of what's going on here. Your hemoglobin has 2 alpha and 2 beta subunits. And in your hemoglobin, you have 2 parts. You have 2 alpha subunits, 2 beta subunits. This is our hemoglobin. Right, and in hemoglobin, we have the heme part, which is basically iron. So we have heme and iron that make up hemoglobin. And this heme is a porphyrin ring that has an iron in the center of it. And so that is what the red blood cells are made out of, just hemoglobin. And basically this iron in the center of the porphyrin ring is able to help transport oxygen from the lungs to tissues throughout the body. Right, so that's how we get oxygen running through our bloodstream and into different tissues. Super important. Let's talk about how, so on average, the typical red blood cell only lasts about 120 days in our bloodstream. And after that, it becomes ineffective, and our body needs some way to get rid of it. We talked about earlier how we can form new red blood cells through our bone marrow, and we're not really concerned about getting rid of our red blood cells because we can produce more. But when that red blood cell becomes ineffective, there's a couple of things that happen in your bodies to get rid of this red blood cell and recycle it or excrete it as waste product. And so, like I said before, we have heme and iron that come from the red blood cells. When we want to recycle these things in your body after they've been used after that 120-day mark, I'm just going to draw the squiggly line. This is going to represent a macrophage. Macrophages are white blood cells, and their job is to break down hemoglobin into heme and iron, the 2 components of it, right? So here, this red box I drew is our heme, and then we have our iron. So macrophage comes along and breaks these things down into the 2 components. Let's talk about what happens to heme first. So heme can go through a series of reactions within our body. When heme is broken down, it is going to become a compound that we call biliverdin. So heme gets broken down. This typically happens by our macrophages in the bone marrow, in the liver, and spleen. So the macrophages or white blood cells takes those old globular proteins, hemoglobin, right? And we're going to break them down into heme group and iron ion. We take that heme group and we're going to put it in the bloodstream. And it's going to become a protein that we call biliverdin. So here, I'm just going to represent that with a B with a circle around it. That's our heme, gets broken down into our biliverdin through an enzyme that we call heme oxygenase. So heme oxygenase does this. So once this became bilirubin and it's traveling through the bloodstream, albumin in the blood can take that biliverdin and it can transport it to the liver. So I'm going to attempt to draw a liver here. Oh, horrible. Oops. And so, biliverdin, sorry, I forgot to mention, biliverdin in the bloodstream becomes something that we call, so before it gets to the liver, biliverdin gets converted into something that we call unconjugated bilirubin. And the enzyme that helps to make that is biliverdin reductase. So this is happening in the blood. So hemoxygenase takes heme and converts it to bilirubin, to biliverdin, I mean. So heme to biliverdin, hemoxygenase does that. And then biliverdin to unconjugated bilirubin is going to be biliverdin reductase is the enzyme that does this process. And so now we have this unconjugated bilirubin, and to get it into the liver, we have to be transported across the protein albumin. So it hitches a ride with albumin, it goes to the liver, and in the liver, we're now going to take this bilirubin that we had, and we're going to conjugate it. So what I mean by conjugate it is that we're going to add on to bilirubin glucuronic acid. This basically converts it to like a more sugary substance. So these G's I'm writing around it is glucuronic acid. And now we call this conjugated bilirubin. By sticking on that glucuronic acid. Now in the liver, the bilirubin can continue to travel, and it can go through the bile duct. So bilirubin becomes a part of our bile, and it can go through the bile ducts and into the intestinal lining. So here, draw this out a little bit. This is our bile duct here. Conjugated bilirubin travels through the bile duct, becomes a part of our bile. It can come into the intestine. So down here, we'll still have our conjugated bilirubin. Now, when we get down into the intestine, what's actually going to happen is we'll have different bacteria that are in the intestine, and these bacteria are actually going to remove the glucuronic acid from the bilirubin. And when that happens, we can convert bilirubin into something that we call urobilinogen. Sorry, I cannot pronounce that very well. Urobilinogen. This is another molecule. We're in the intestine at this point, right? And this urobilinogen it has a couple of fates. So, from the intestine, the urobilinogen can go back into the bloodstream. That's one of its fates. It can be recycled into the bloodstream. Another fate is, so it's absorbed through the intestinal lining into the bloodstream. Another fate is that our urobilinogen can travel through the bloodstream and into the kidneys. Right? We make it here to the kidneys. We make it here up to the kidneys. Urobilinogen. Let me write out that word. So UB is equal to urobilinogen. Urobilinogen can be converted in the kidneys to something we call urobilin. So in the kidneys, it can become urobilin. Urobilin is then excreted into our urine as waste product, and we just get rid of it in the urine as a part of our pee. And so this is what makes our urine. It gives it its yellow color. Urobilin is very yellow. So the last fate for urobilinogen is it can become stereodilin. And this just remains inside of the intestine. It does not leave. If it becomes stereodilin, it becomes a very dark brown color. And let me see if I have my brown still. It becomes dark brown. And it gets excreted as a waste product in our feces. And so that's why our feces have a dark brown color. And that's the fates of the heme group. That's what can happen. Another thing I want to talk about is the fate of iron. So, iron really only has one other possible fate that can happen with it. So iron's going to bind. It binds to transferrin molecule that transfers iron to protein ferritin for storage in the liver. So basically just gets transferred to protein ferritin for storage in the liver. Okay, so that is all of the fates of hemoglobin, what can happen to it? So that's the composition of our blood here. Right, this whole thing. Now, let's talk about the next concept that I wanted to review today, and that is going to be hemostasis. So let me give a quick definition of what hemostasis is. So, let's zoom in just a little bit there. Oh, right, this is just a tad bit bigger for y'all. Hemostasis is basically the cessation of bleeding, like how we stop bleeding in our bodies. And this can occur through three steps. The first step is going to be what we call vascular spasms. The second step is what we call platelet plugging, or making a platelet plug. And the third step is a blood clot formation. So what's really interesting about this process is it keeps us alive if we cut ourselves. Imagine if you were to get a paper cut, but you were never able to stop the bleeding. If your body was not able to perform hemostasis, then you would bleed out due to just a simple paper cut or a simple prick of a thorn that you touched on a trail. Your body would not be able to stop the bleeding, and we would die due to just bleeding out. And obviously, we don't die when we bleed out. We have hemostasis to help us recover from such minor injuries, right? And sometimes it's bigger, but this is really intriguing and really fascinating how our body is able to stop bleeding on its own. So let's talk about some of these processes. So first, let's talk about vascular spasms. So in a vascular spasm, basically what happens is we damage our body, we get a cut, we start bleeding out. The very first thing that's going to happen is our body is going to want to constrict blood flow to that area that we're bleeding out. And we don't want to amplify the amount of blood that's coming out, so we're going to try to constrict blood flow there. And this is accomplished through stimulation of the smooth muscle contraction around the damaged blood vessel. So when we stimulate the contraction of smooth muscle around the damaged blood vessel, we're basically just like tightening up that blood vessel. We are decreasing the diameter of the blood vessel. And this can even be as extreme to where it gets to the point where we have complete closure of that blood vessel or occlusion. Like we can completely close up that blood vessel to where no blood is rushing to that area, so we're not going to lose blood very quickly. This is a great way to initially stop bleeding, but it's not very strong and only lasts so long. So we need other ways for our body to combat bleeding. So next, this vascular spasm will only last so long, and eventually the blood vessel will relax and the bleeding will occur at a quicker rate. So our body has other mechanisms to stop the bleeding. The next one we're going to talk about is a platelet plug. The formation of a platelet plug. And so, let me draw up a picture for this. Just say, here we have the bloodstream. And on our bloodstream, we have a bunch of endothelial cells. There's these little curved shapes I'm drawing here. These are going to represent the oops, didn't mean to change the color there. These are the endothelial cells. In the bloodstream. Within a blood vessel, right? These are on both sides. I'm just going to draw it on one side for simplicity. Or we could, let's see here. Draw up the next thing and we'll see what I can do. Here, this blue squiggly line is what I'm going to call our basal membrane. Just outside of that blood vessel. And so, or just a part of the blood vessel there, right? So, excuse me, the see, oh, there we go, perfect. All right, so now we have a completed blood vessel there. The picture I wanted to draw. When we're talking about platelets plug formation, let's say we had a damaged area to our endothelial tissues, the endothelial cells right about here. Let's say we accidentally cut them up right there and we have damage there. What's going to happen is the very first thing that happens in this case is, like we talked about, we'll have vascular spasms to constrict blood flow to that area. But then the next thing that happens is we're going to release something from the endothelial cells called von Willebrand factor. So that's, I'm going to abbreviate here with VWF. But that VWF means von Willebrand factor. So we cut ourselves, the endothelial cells immediately think, okay, let's release von Willebrand factor so that we can start this platelet plug formation. So next thing that's going to happen is within the bloodstream, we have platelets, right? Platelets are always just floating around. So kind of like little pieces, they look like little pieces of rice if you were to look at them under a microscope. But these von Willebrand factors are actually going to go, and when they're released from the endothelial cells there, they're going to go and they're going to bind to these platelets. Now, when they bind to these platelets, what's going to happen is these platelets are going to move and they are going to bind onto our basal membrane over here. And the von Willebrand factors help this platelet bind to collagen within the vessel wall, right? And so these von Willebrand factors are binding to collagen here within the platelet wall. Now, when they bind to collagen, a couple of things happens to that platelet. And this is a process which we call the platelet becomes activated. And so notice before how the platelet looked like a little piece of rice. When the platelet becomes activated, it changes shape primarily. And then within the platelet itself, there are a couple things we want to talk about. So in the platelet, we have alpha granules, which I'll represent with these little orange dots. We are alpha granules. Our alpha granules are going to release a couple of things. So they release more von Willebrand factors. They are going to release fibrinogen, and they will release PDGFs, platelet-derived growth factors. And so von Willebrand factors are going to assist in further platelet formation, while your platelet-derived growth factors are going to assist in long-term wound healing of the damaged tissue. So these PDGFs, platelet-derived growth factors, help to assist in long-term wound healing of tissue damage, while the von Willebrand factors are going to assist in further platelet formation. We'll talk about what fibrinogen does here in a second, but let's draw up one other thing here. Let's do the next color is a light green. And we're going to release another type of granule. So we have our alpha granules, right? We're also going to have something that we call dense granules that get released. And so dense granules, they release some other things. They're going to release ADP, adenine diphosphate. They will release calcium, and they will release serotonin into the blood. Serotonin. There we go. That's how you spell it. So these dense granules are releasing that. Another thing that's going to come off, that comes actually from the membrane when it gets damaged here, is thromboxane. So I'll just demonstrate thromboxane here, and it's going to come out. Thromboxane can also be known as TXA2. And this is a type of prostaglandin. And so let's talk about what thromboxane does and what actually, in conjunction with thromboxane, what ADP is going to do. So what they help do is they're going to bind to surface receptors on additional circulatory platelets. And they're going to promote further activation of those platelets. When those platelets are activated, they'll start to release their own granules as well. And it'll just kind of lead to this chain reaction. But, so each of our platelets have different receptors on them, per se. Like here, we could draw up, this could be in ADP receptor, right? Where when ADP binds here, it is going to is going to activate this platelet, go through the same change in shape and release of granules. Let's say over here we have a thromboxane receptor, so a TX2A receptor. When thromboxane binds there, it's going to do the same thing. It's going to activate this platelet. And so we have all these activation of these platelets, and we're building up in all of these molecules and Van Willebrand factors, fibrinogen, PDGFs, ADP, calcium, serotonin. This is all happening at once. Now, this is all important because it leads up to what finally happens. As we activate more blood platelets, we are actually able to use that fibrinogen that we created. And fibrinogen on it has its own little receptors. And I'm just drawing up some random platelets here. Let's just draw one more and call that good. But, so, before we talk about that, let's come back. I'm just going to mention, over here, when we activate the platelets, we have a fibrinogen receptor that comes off of them. I'll demonstrate that in silver. But each of these little silver things I'm drawing is a fibrinogen receptor. And the specific name for this is going to be GP2B3A, which is a fibrinogen receptor. So, we have all these platelets that got activated. All of them have their own little fibrinogen receptors on them. But what's going to happen now is at each of these fibrinogen receptor points, we can start to actually interlink fibrinogen. So fibrinogen was released. Fibrinogen is going to go and bind to fibrinogen receptors. And what happens is they're actually this fibrinogen will bind to both receptors in the same area. And what it's going to do is it's going to stick these platelets together. So fibrinogen acts as a bridge to hold the platelets together, and we're going to just keep clogging up a ton of platelets in that area. So imagine that this was happening over here. And as all of these platelets are getting clogged up in the area where we find our wound, this is what we call a platelet plug. So the main job of fibrinogen, like I said, is to act as a bridge that holds platelets together. And as we get more platelets bonding together, we form something that we call a platelet plug. Now this platelet plug serves a further purpose to help reduce the amount of blood that we're losing when we receive damage in that area. And so that is our platelet plug. Now we can keep going. Let's see here. Let me see if I'm missing anything else. No, we can keep going here. Yeah. Let's go on to the last thing. So we talked about vascular spasm. We talked about the platelet plug. Now let's talk about blood clot formation. So, another word for this is going to be building fibrin strands. And so, if we take our, oh man, let me see if I can snag, I can snag this one. Take our membrane again, our blood vessel, bring it down here. Let's make another one right up here. Flip it around. There we go. And we're going to need just a hair bit more space for this. Make it a little bit wider. Oops. Did not mean to do that. A wee bit wider there. Okay. So now, let's go back to making that area of damage. Just put it right there for now. Now, when we start making our platelet plugs, we're also going to have other compounds within our bloodstream that are just kind of hanging around, and they help to reduce bleeding as well. They help in the process of hemostasis. And so, the first pathway I want to draw up is what we call the intrinsic pathway, or the pathway within the blood that leads to fibrin strands building up, or we can call it the blood coagulation pathway, or the blood clot formation pathway. So compound 12 will go and rush to the site where we had our injury, goes into the membrane, and it interacts with collagen. So it's going to bind. This is going to specifically bind to collagen in the membrane. So factor 12 is a serine protease that has a positive charge and is attracted to the negative charge of collagen. and this is what starts our intrinsic pathway. It becomes factor 12A, or the activated form of 12. This will then become factor 11, which becomes factor 11A, the activated form of factor 11, right? And then it becomes factor 9 is going to interact with factor 11A, and this will become factor 9A. And at this point, we're also going to have factor 8 that works as a cofactor here. Along with that, we'll have something that we call the platelet membrane phospholipid. So I'm going to abbreviate that with PL, the platelet membrane phospholipid. And we'll have calcium that binds as well. So factor 8 is an important cofactor, along with those other things I mentioned, for, I might put these right up here so we have some more room. For factor 9A to do its job. So factor 9A is going to now, so this is what we call our intrinsic pathway, right? Intrinsic meaning it's within the blood vessel, within the bloodstream, inside of it, right? And one thing that can block our intrinsic pathway is heparin. Heparin's a drug, so heparin can block this pathway. Okay, so now let's talk about a more common pathway that we will use between our intrinsic and extrinsic pathways. So here we described our intrinsic pathway through these steps, and I'm just going to color code that in green for us so that we know. As I go through these, we don't confuse them, right? And this is the intrinsic pathway. That's a part of it too. So now let's talk about what we call the common pathway. So factor 10 is going to interact with factor 9A, and it becomes factor 10 activated, right? And then we're also going to have cofactor of factor 5, the platelet membrane phospholipid, and we'll have calcium here as well, that work with factor 10A. Now we're going to have factor 2 that interacts with factor 10 to become factor 2A. And then we're going to have factor 1 that interacts with factor 2A to become factor 1A, and factor 8. It's another cofactor here. So as factor 1A and factor 8 interact, they will become factor 8A. So let's put some names to a couple of these terms here. Factor 2 is what we call prothrombin. Factor 2A is what we call thrombin. Factor 1 is what we call fibrinogen. factor 1A is what we call fibrin. And then factor 8A is just a stable fibrin clot. Meaning, so yeah, let me explain a couple of these terms a little bit further. So when we're talking about fibrin, basically the job of fibrin is to create this thing that we call a fibrin mesh, which strengthens the plug that we made before. So the fibrin and as we learned before, fibrin is converted as we converted the molecules of prothrombin to thrombin, and then use thrombin and fibrinogen to make fibrin. When we convert thrombin to fibrinogen into fibrin, eventually, fibrin can create a fibrin mesh that strengthens the platelet plug that we made. And so the red and white blood cells that are going throughout the bloodstream, instead of bleeding out and coming onto our skin as a form of blood, they're going to be caught in the fibrin mesh. And so that kind of slows down the loss of blood. This is going to increase the ability for hemostasis to be effective. And so red and white blood cells get caught in the fibrin mesh. And so this leads to a decrease in the loss of blood. Alright, so let me highlight that pathway we just talked about. This is going to be common to both intrinsic and extrinsic pathways. We're about to talk about the extrinsic pathways here in a second. But because it's common to both, this is what we call the common pathway. Now that we've talked about the common pathway, there's just one more that we need to address. And that last one is what we call the extrinsic pathway. And so in our extrinsic pathway, let's see here. We'll start on the outside. So the extrinsic pathway means we are on the outside of the blood vessel. And so, fat molecules that accumulate. But, here. On the outside of our blood vessels, or within that base, just outside the basal membrane area, we have a factor called factor 3. This is also known as tissue factor. And this tissue factor is just going to be all over the place here, right? Find it in fat, find it in your muscles, right? and it's just going to be all over the place, just all over the tissues, right? So, basically, oh, and then one more name for the tissue factor, we can call this tissue thromboplastin. So, as I was saying before, this is found within our tissues, and it senses when we have a damaged endothelial cells as well. So the tissue factors are going to interact with, let me move this down just a little bit. Imagine that we were near that wound site still. But I'm going to put this over here just so we have some room. Tissue factors interacts with factor 7 within the blood vessels. And factor 7 will interact with the tissue factor to make factor 7A, the activated form of it. And this is going to involve phospholipids and calcium as well. We're going to help aid in this process to make the activated form of factor 7. And so this is what we call our extrinsic pathway, because we use an external source, factor 3 or the tissue factor, to help activate factor 7 within the bloodstream. And our extrinsic pathway here, we can go from 7A directly to converting factor 10 to factor 10A. And so this is a part of the common pathway, right? This right here. Just drew up, that's a part of our common pathway. But everything else above it here, this is a part of our extrinsic pathway. All this stuff, right? The tissue factors, all that. That's a part of our extrinsic pathway there. And so, these are two pathways, intrinsic and extrinsic pathways, that help with blood clot formation. And super important because this is the last step that secures, that helps us to complete the process of hemostasis, or stopping our body from bleeding out. And so let's just talk about a few more things. We're almost there. Let's talk about the drug that is going to block the extrinsic pathway. This drug is called Coumadin. Coumadin, also known as warfarin, is going to specifically block vitamin K activity in the liver. You might be asking, how the heck does vitamin K activity have to do anything with factor 7? Well, actually, vitamin K is super necessary for factor 7 to be produced and to be functional. So vitamin K is a necessary precursor for factor 7. So if we didn't want the extrinsic pathway to be clotting blood, we would just give somebody warfarin to act as an anticoagulant and block factor 7 from being fully functional. Another drug that we can talk about is, let's see here, talking about that one. Another drug that we can talk about is going to be involved up here in platelet plugging, and the drug's name is aspirin. And aspirin, what it does is it prevents aspirin is going to prevent prostaglandin synthesis. And another drug named Clavix is going to act as an ADP inhibitor. So there's a few of the drugs that we want to keep our eyes on. So remember, prostaglandins like thromboxane can help to activate more platelets to help in the process of platelet plugging. And then ADP does the same thing. It helps to activate platelets, but if we're inhibiting ADP from doing its job or preventing prostaglandins from being synthesized, then we can't have platelet plugging, and we can't continue onwards with our hemostasis. Sometimes it's necessary to block hemostasis because if we have an embolism in the blood, an embolism is just a blood clot that's basically moved away from the tissue that it was trying to heal, and it can get stuck in other smaller vessels within the body, and it can actually cause a lot of problems. If we have a blockage in blood flowing, especially to important organs like our heart or our brain, that could lead to serious illness, even death. So sometimes we need to introduce drugs to help stop blood clotting so that we can help patients in the future. Now let's talk about one last process that happens in our body. We call this fibrinolysis. This is kind of the whole idea of anticoagulants. Like, if we don't want if we don't want the process of hemostasis to be working or working when it's not supposed to, so fibrinolysis. So let's talk about this process. So our liver can release a certain molecule called plasminogen. And Plasminogen is basically an inactive form of an enzyme. And that enzyme is called, the enzyme is called plasmin. And so plasmin is an enzyme that is responsible for degrading fibrin. So it's an enzyme that degrades fibrin. And so some ways that we can, so plasminogen is a type of a zymogen, and zymogens are just proteins that aren't activated until you break them apart a little bit. And so a couple of ways that we can convert plasminogen into plasmin. Well, one way that we really care about in this class, and I'll just focus on in this video, there's another way we can do this, but we'll just keep it simple, is through something that we call tissue plasminogen activator, or TPA. So it is going to aid in this process of converting plasminogen into plasmin. So when we notice that patients might be experiencing a heart attack or a stroke that could be caused due to an embolism, administering this tissue plasminogen activator to them could be really crucial in helping them survive and overcome that difficulty in the moment. And so tissue plasminogen activator, when it's administered within 90 minutes of the onset of the symptoms of the stroke or heart attack, is going to work most effectively. And so that's just a little plug for clinical applications of TPA, or our tissue plasminogen activator. So plasmin, as said, it is going to act like a pair of scissors, and these scissors are going to chop up fibrin. So fibrin gets chopped up, and it leads to fibrin degradation. Products. TPA, like I said, converts plasminogen to plasmin. Another thing that can help do this is urokinase. We won't go into that today, but it's just another molecule that helps this process here. And so that is what we should know about hemostasis. It's a little complex, and it's a great blessing to us in our lives, because our bodies are capable of these great complex processes that keep us alive and help us to be where we are today. So I'm going to end my video with that. Thank you guys for watching, and